Hello, and welcome to Informatically Speaking, a Greater Delaware Valley ANIA podcast designed to promote knowledge sharing in the field of nursing informatics, locally, nationally, and globally within our unique industry. At GDV ANIA, we are committed to providing opportunities for professional development with the goal of advancing nursing informatics practice. I'm your host, Constance McLaughlin. Welcome back to GDV ANIA's podcast, Informatically Speaking, a podcast for practicing informaticists and informatics enthusiasts alike. Today, we welcome Dr. Craig Joseph. Craig is the Chief Medical Officer for Nordic Global, which is an international healthcare management consulting firm. Craig has 30 years of experience in IT and healthcare. In addition to practicing medicine as a primary care pediatrician, he worked for Epic, where he helped customers implement and enhance their system, as well as help to build their foundation system, and has served as CMIO at multiple healthcare organizations such as Agnesian Texas Children's, Camino Health, and Children's Seattle. Dr. Joseph is the co-author of Designing for Health, the Human-Centered Approach, a book that promotes the intentional application of design to the particular needs of clinicians, hospital staff, and patients. Sounds interesting, and that's what we're jumping into. Hi, Craig. Great to have you.
Hello. Thank you for having me. I'm excited to be here. I'm excited about the clinical informatics enthusiasts. That seemed like I'm not sure who those people are, but I want to meet them.
Me too. And I'm sure they're listening. I am sure of it because.
All right, reach out to me on LinkedIn. Tell me who you are.
Awesome. I want to talk about this book because it's right up my alley. It is so it just touches my heart, this whole way of designing around people. Because of being in healthcare and in the IT industry for a long time. We've both been there for a long time. People tend to focus on this technology and they forget all about what's happening around them. It's kind of been my torch, I would say probably the past 15 years. So give us, before we get started, a little bit of a glimpse into your informatics life, and then let's talk about what prompted you to write this book.
Sure. From an informatics perspective, I was kind of geeky before it was cool to be geeky, and I'm very, very old. So when I was in middle school, I was teaching myself to program on a Radio Shack TRS-80 color computer. This is in the early, I know, with 4K of RAM. And if I wanted to store data or program, I did that to a cassette tape. It was pretty cool. And then I majored in, I knew I wanted to go to medical school, but I majored in computer science. So I got a computer science degree and I then went to medical school to become an emergency medicine doctor, and then did emergency medicine. I was like, oh no, I don't like this. And ultimately did a pediatric residency and practiced primary care peds for a long time. Looking back on it now, people say to me, well, that was very insightful of you, that you knew even back in college that you wanted to combine technology and medicine in your career. And I say, that's exactly right. I was very smart. No, in fact, I just thought computer science would be an easy major for me. And I could get good grades, and I needed good grades to get into medical school. So it was just that simple. So no, I was practicing pediatrics, and I was kind of looking for more out of my life, and was trying to decide how I could. Was there something I could do that did combine technology with clinical practice and healthcare? And this was in the early 2000s, and applied to a couple of electronic health record vendors, which this was, again, 2003, 2004. there were not very many hospitals that were using
Right.
that kind of technology. And so, yeah, so that's how I became that's how I came to work for a big EHR vendor. And from the informatics standpoint, it's kind of just I figured it out. There were no informatics fellowships at the time, of course, when I was in training. That was far from a concept. And so yeah, we figured out the technology was pretty easy. Figuring out how to get it, doctors and nurses and clinicians in general to use it was the hard part. So yeah, those were the days where you figured stuff out, and now we have a fellowship for I think there's for nurses and for physicians who can take a formal class and pass a test. But back in the day, it was just figuring stuff out. And so that's my clinical informatics background. I still have to take, I had to take a test to pass the informatics boards. And I have to do questions and to recertify regularly and all of that. And I look at some of those things that fellows are being taught, and I'm like, I have no idea. I have to go and look this stuff up to try to figure it out. It's not kind of day-to-day stuff, I think, that most of us in informatics work on. But I also know that I figured a lot out, because I go to one question, I'm like, that is the dumbest question. It's so obvious that there's only this one answer. And I know that there are people who it's not so obvious for, and they haven't gotten yelled at and thrown out of the OR. I was actually thrown out of an OR once. I'm pretty excited to say that. And it was a children's hospital where you don't normally see that kind of aggression, but I was thrown out of an OR when I worked at Epic, because the surgeon just was not happy with life. I didn't do anything wrong. I worked for Epic and he didn't want me there.
Yeah.
Yeah. So we've moved a long way. I don't think that happens anymore. But yeah. And you want to talk about the book? I can tell you the origin story.
Yeah, I'd love to hear the origin story, because I do want to get into the topics, the content of what you got in there, because I find it really interesting. But yeah, tell me how it came about.
Yeah, the joke is from my co-author that Craig, have always wanted to write this book since the CEO of my company told me I did. And so, no, I've never really seriously thought about writing a book. This is the truth. The CEO, he's no longer our CEO, but he was the CEO at the time. And I was in a meeting in a conference room, a glass. We've all been in those kind of goldfish kind of bowls. He was walking by, kind of gave us me and someone else a nod, and then backtracked and opened the door. And he looks at me and he goes, "Hey, Craig, I was thinking you should write a book." And I just looked at him, and he's like, when I was at a previous firm, we had a doctor. He wrote a book. It was great. Like, it helped our clients, and it gave us goodwill, and it was great. You should write a book. And then he just walks away. And I looked at the person that I was with, who was my boss, and I said, was I just being punked? Like, is there a camera? What's going on? Was he serious? And she says, "I think he was serious." And so he basically said, write a book. It needs to be on healthcare, and it needs to help our clients. And that was pretty much it. And do it on we're not paying you, but you're going to do it on company time. And so I thought about design, because I've been an armchair kind of. I never took a formal class in design, but I read books, and I've watched countless, pretty much every hospital system that I've been at, as a consultant or as an employee or whatever. I've watched over and over where people who don't know anything about design, basic design,
Mhm.
make decisions for how other people are going to use tools, most prominently technology tools, most prominently of those, the electronic health record. They would make decisions about, how this thing should be configured, basically how it's going to use, what the workflows are. And they just made bad decisions. And often they had people at their organization who were much smarter than me, who were experts in human-centered design or human factors engineering, who were just roundly ignored. Like, well, we could probably do it this way. No. We're going to ask the chief of cardiology. Okay, well, there's multiple reasons why you should not ask the chief of cardiology. Because, and reason number one is the chief of cardiology is probably never going to use this thing because they have people that follow them around and do stuff for them typically. And they're the last person to ask. But yeah, so I thought, can I, and I brought in a colleague of mine at the time who's much smarter than me. I said, can we kind of distill down some basic ideas about design and say, hey, if you read this, you're not going to be a designer, although we all are to some extent. You're not going to be a professional designer, but you will at least get an appreciation for what those people do. And maybe if you're a senior leader in some healthcare system, you will get out of their way and let them do their work, these designers that you probably didn't realize that you had working with you. And if that's the case, if all that you learned is that you should not be dabbling in this area, CEO or CMO, and you should let the people who do this for a living do it, then I have succeeded in so that was the goal of the book. Yeah, we included a lot of, so it's written for kind of, I always say it's written for executives, which means it doesn't use big words and it doesn't have a lot of dense text because I know that they won't read that. Every chapter begins with like a little clinical scenario, which kind of, I hope, makes it clear to folks like, hey, we're not talking about this obtuse subject. Like, here's how this principle was not applied or was applied in a clinical setting. And here's the good thing or bad thing that happened because of it.
Well, that's a great segue into where I want to get started because it's so informaticists, as informaticists, we really should be, like we already said, out there looking at what's happening. So, I mean, this book is like so in line with what we're doing every day or what we should be doing every day. Being out there, observing, understanding what's happening in the healthcare setting, and then understanding how the technology relates to that really, and how we're able to enhance clinical workflows. So, in your studies and as you were writing this book and just your experience too, because we bring it all with us, how should we be looking at how humans work?
I think just at a basic level, and again, I always stress to people, I'm the expert often in the room about design because there's no one in the room that knows anything about design. And so the bar is very low. I just think that there are some basic ways that humans think and react that are predictable, not always in our best interest, but just predictable, and we kind of know how people think to some extent. And again, I'm overgeneralizing. Most people, when they're looking at a list, have a sense of how that list is going to be ordered before they start looking at the list. And so if I were to give you a list of colors and I wanted you to find the color red, most people are going to start scrolling at the time because the list is probably going to be in alphabetical order. Like that's what's going to make sense to most people. Like they would expect they're even, whatever the first couple of things are, they're just going to start scrolling down because they're going to expect it. But if I gave you a list of numbers that were written out and I said, find the number 10, you're probably going to look at the 10th spot. You're not going to go in alphabetical order because you're going to expect that the first entry is going to start with an O, which is weird, right? It's going to be 1. And so just knowing that, okay, well, that's how generally people think, then we should follow that and we should leverage that and kind of let people figure out how to create muscle memory and use pattern recognition, which is what we do in healthcare all the time. Right? We don't call it pattern. Well, we do call it pattern recognition, but most of us don't think about it. I remember when I was practicing, I don't practice now, but when I was practicing, I worked in a small office most of my professional career. This was with one other doctor. And so I pretty much knew all of our pediatric patients because there were just 2 of us in the practice. And so I knew the parents pretty well. I walk into one room during stomach flu season, and this mom had a child who had some vomiting going on, and she was very concerned. And again, I knew her, and I just walked in, and she starts talking. Well, he's thrown up this many times. He's had this much diarrhea, and I looked at her and I said, "Listen, I'm going to get all of that information from you, but I've already decided what's wrong and what I'm going to do." And she said, "Well, you haven't even you practically haven't even walked in the room yet. How could you possibly do that?" And the answer is pattern recognition, you know?
Right.
And so I told her, and again, I share this because this was someone who I knew well, and I could talk to her this way, the mom. I said, "Listen, you can tell me he's thrown up 85 million times, but I have a child who's sitting up looking at me with spit, he's drooling. I know he's hydrated. It doesn't matter. I
Right.
know he's hydrated. And so he's not my choice with stomach flu, if that's what this is, and that's what it was, is to send him to the emergency room for IV rehydration or not. That's it. I got no medicine for you. I got no other special things for you. Either you're dehydrated and you need IV rehydration, or you're not." And I said, "Of course, I'm going to listen to you and you're going to tell me what he said, what he's doing, and I'm going to examine him, and I'm going to look in his ears, even though probably doesn't have an ear infection. And I'm going to listen to his heart and his lungs and all of that stuff. I'm going to press on his belly." But pattern recognition allowed me to already figure out that all of these things were most likely going to happen, and I could know that. And we use that all the time, and we call it muscle memory when it's technology. But doing the same thing, the same way with our technology makes it easier for us to kind of adopt it and then use it. And so I was just talking about that list again. If there's a list of medications or medical problems or whatever it is, it should work. That list should be consistent throughout the electronic health record or the workflow that I'm using. And people make changes like, oh, well, on this floor, they use this procedure most commonly, so we're going to put that near the top so that they can get to it quickly. Okay, but then I'm on the next floor tomorrow, and it's in a different area, and it's not, now it's at the bottom, and I'm like, why is it different? And so these are just basic, I think, things that is consistency, transparency, predictability, things that we want, but we sometimes often we don't know how to say it. We just say, "Oh, this sucks."
Yeah.
Right? That's what we say. We say the software sucks or the vendor sucks. When often it's not the software or the vendor, actually, it's the people who put the thing together at the final moment. And so, yeah, those are just some of the basic chapters. Getting rid of stupid stuff, like that's actually a chapter title, and there's a good story about that I can tell you. Or how you make choices, what choice architecture is. Just
Yeah.
again, nothing in this book is groundbreaking, I don't think. I've stolen from everyone else. I've given them credit, so it's not really stealing. But these ideas are just are constants in humanity, and working with them instead of trying to fight against them, swim against the tide, just makes life much easier for all involved.
Well, but it's interesting because we don't often think of this stuff, right? So, I mean, like you said, it's stuff that we do all the time, but we don't think about how we're doing that. We just inherently expect to see things the way that we think it's going to be. And then we make decisions based on other things that are going on around us or that are taking our attention. But those things are just the things that we're expecting that list to be a certain way, like in alphabetical order, not in color coded order or whatever. And we don't want to scroll, and we don't, we don't want it to suck, because we have to go looking for things, and it should be right here in front of me all the time. And then we get into the whole people are uh, the people that are offering solutions versus us listening and just saying, what is the problem? Like, don't tell me how to fix it because you don't really know how to fix it. Just tell me what the problem is. And then, you mentioned choice architecture, like trying to make things easy. And I guess then I try to think about connecting the technology that is rigid, right? I mean, you can make changes to it depending on where you work, if you're allowed to make changes to it or not. But you can make the changes there, but it's still rigid. So it's, again, it's that human factor, how they're actually using the technology in their workflow. And depending on who you talk to, who's saying, well, the technology should be changing the way that you do things, or no, the technology should fit into the human workflow of it all. I just find it interesting, and it's like I don't know, how do we make it easier for people to make the right choice as a human with their biases, with the a million decisions that they're making, and using this rigid technology. I don't
Yeah,
even
and
know
the
if that makes sense.
yeah,
I'm
no,
I'm
well,
rambling.
the computer's just ones and zeros, and there's not a lot of
Mm-hmm.
gray there, right? And to your
Right.
point, like um, some workflow, some technology, some tools are very rigid, and others are configurable. And when people say like, well, which is right? Should I have to change for the technology? Should the technology have to change for me? My answer is always yes.
Mm-hmm.
Um, and people don't like that. They're like, no, no, no. It was an A or B decision. And I'm like, well, hey, sometimes like you do stupid things, okay? Like, I'm sorry, but it doesn't make any sense that you still do this thing, and you should stop doing this thing. And the technology is making it forcing you to stop doing that thing. And that's, I think, a fine use of technology, right? Because it's purposeful. It makes sense.
Yeah.
However, well, we designed it this way. Yeah, but that doesn't. I can't do this thing before that thing. That doesn't flow for me. Not only does it not make sense, but it's not something that could actually ever happen. Well, then, yeah, the technology is the thing and that's broken. And so I think there's some middle ground that is the right answer. And I think the secret is intentionally thinking about these things, which is what we often don't do. And I'm as guilty as anyone. And so, you know, just like, well, what's the problem? Well, the problem is that people aren't filling out this form. Okay, it's on paper, so we'll just make it in the computer. Okay, well, let's think about this from the beginning, though. Okay, what's on the form? Do we need the form? Do we need the information on the form? Who's supposed to fill out this information? Um, and so, kind of just thinking through from the beginning with no trying to not have any preconceptions, which is hard for us, especially if we're deep in the organization, have been there for a long time. We think things or need to be a certain way because so and so said they had to be that way, even though so and so retired 5 years ago. Um, kind of going back and like, okay, well, what's on this form that is so important? And if the answer is no one really knows, then I'm not interested in digitizing that form or incorporating that form into the workflow because it doesn't have information that's relevant or that information's already been collected. Why are we collecting it again? Wouldn't it be smarter? I'm saying this to my doctors now who are not listening. Wouldn't it be smarter for you to just go over to, show me the information that I've previously supplied to you or that you just got from outside organizations and ask me to validate it? Wouldn't
Yeah.
that be a lot better than giving me a blank form every single year and asking me to fill it in? That doesn't, which I know you're not looking at. It's not possible that you're paying attention to all of these things every single time. So yeah, there are. We just have to think through what we're doing. Maybe following. I remember when I was a third year medical student, a senior resident at a code blue, patient was needing CPR. And I get up to the room and he looks at me and he said, first thing we do, take our own pulse, right? Just stop, look around, don't start running. I heard another attending say, don't just do something, stand there. Both, that was an internist for sure. Don't just do something, stand there. Point is like, hey, if you're just running in and doing something, often you're doing the wrong thing because you haven't looked at the situation from the 30,000 foot view and kind of looked around the room. You can do CPR all you want. If the patient's got horrible hyperkalemia, you are never going to shock them back to life. You need to resolve their potassium problem, right? And so it's the same thing, like kind of rushing in and going like, well, we're just going to add this technology because we have a problem and we have the technology, so let's add it. Okay, well, technology may not be your problem, it might be an operational problem. Yeah, I think we've all got experience where we fill out, we call it paperwork. Hey, I need you to answer these questions before your visit. And then you show up to the doctor's office. And again, I'm talking to my doctors, and they give you a piece of paper. And they're like, okay, you need to fill this out in the waiting room. And when I say, well, I filled it out online, like you guys asked me to answer these questions, I've answered them. And they're like, well, we don't know what you're talking about, or doctor prefers this, or things like that, where it doesn't really, it doesn't make any sense, and no one's really thought it out. That's an operational problem. That's not a technology problem. We need to get everyone rowing in the same direction before we throw technology at it. Someone thought, we'll solve this problem, we won't need this paper, but they didn't talk to the people on the ground.
Yeah. Well, that's something that we all live through. We've lived through it for so long, and having been as old as you, older than dirt, going back to the early 2000s, where we just getting started with this, and every single piece of paper went into the system. And everybody was still filling it out. And then it was, well, we had this issue, this event happened, so now we're going to do this as a result of it. So here's another form in the system to do. Oh, and by the way, nursing can do that because nursing's already in the room. Like nursing now has so many things that they're filling out. And oh, by the way, yeah, everybody's doing their own assessments. I'm telling you what, I can go on for hours about this. I mean, it's just the whole thought of, I'm a former ICU nurse. So, we would have respiratory coming in, do their assessment, and then write in the vent settings. Well, then I had to do the same. I had to put my version of the vent settings in too, and they haven't changed, right? Because they're the same. Like, why am I not just pulling that information over? I'm telling you what, I could go on for hours about this, but you're right. It's getting rid of the stupid stuff. Why are we putting this in the system, or why are we adding another step when something that is operational, that all they have to do is walk around the desk the opposite way and get what they need versus having to fill out another form online?
Yeah. Well, it's funny. So you brought up the gross, and I have a great story. So we actually have a chapter entitled Gross, GROSS, which means getting rid of stupid stuff. And I had mentioned that I wrote this book on company time, which meant company lawyer read the book before it became a book. And the company lawyer came to us and said, you can't use this term, gross.
What?
And I said, well, what are you talking about? And she said, well, it's almost like you're implying that our clients do stupid things all the time. And I looked at her, I'm like, I tell our clients they do stupid things every day, right? Like they are paying us half the time. They know they're doing these things.
Yeah.
I mean, I don't use that word, but sometimes I do. I'm like, yes. So yes, you are correct. That is what I'm saying. She goes, well, that's just not an appropriate term. And then I showed her the New England Journal of Medicine, well-regarded New England Journal of Medicine article entitled Gross from the CMIO at Hawaii Pacific Health, Melinda Ashton. And she wrote this just like 3-page article which was accepted by the New England Journal and kind of became famous among informaticians and some other folks in healthcare because she just went around and asked people to submit things that they thought in the EHR and in other technologies that were just didn't make any sense,
Mm-hmm.
So, why are we collecting? I think there was an example that somewhere nurses for a 6-month-old checkup were having to discuss the umbilical stump status. Was the umbilicus oozing? Which is an awesome question to ask if you're 4 or 5 or 6 days old. Really
Right.
not a very good question for a 6-month-old, because if they still have their, if their belly button's kind of attached, like we've got bigger issues if that's
Yeah.
a thing that we're talking about for a 6-month-old. So, but the nurses were just like, either they didn't know how to complain, or they thought that it would fall on deaf ears. And so there were things like that, that was clearly a mistake in the configuration of electronic health record. You should not have been being forced to document that on a 6-month-old, and they fixed it instantly. But one of the things that I think I took away from this very famous article called Gross was, a lot of things are just why. Like, we need to explain why the things are the way they are. So she basically opened up to the entire hospital saying, hey, tell me all the things you think are dumb. And then, people would say like, well, I think this is dumb. And they would come back after they had done their research and said, oh, well, actually, this is a regulatory requirement, and here's the regulation, and here's how we interpret it.
Yeah.
And it doesn't really matter if we think it makes sense or not, because we're required to do that thing. And well, that's awesome, because now it's not that the EHR sucks or that my CMIO sucks. It's that the regulation sucks, which is true if it is, if that's
Very
what it
true.
is. And so, okay, so now, well, our compliance officer says this is the interpretation of this rule. But we've talked to a hospital across the street, and they interpret it very differently. And so now we can have this kind of conversation about, should we reevaluate how we interpret this? But the point of it was like, hey, let's just put all the cards out on the table. Here are the ones we can fix. We fix them. Here are the ones where like we would love to fix them, but the EHR vendor doesn't, we're not there yet, or that's a big project and we don't have the money for it, but you're right. And it's on our list, and hopefully we'll get to it sometime. Those kinds of things, and being transparent about it really, really help. And with adoption and with morale, right? Because oftentimes your help desk turns into, well, I told the help desk people about it, and what happened? I don't know. Never heard back.
Right. That's exactly right. I mean,
Well,
but
yeah, if you don't want to get help desk tickets, don't respond to help desk tickets. And very
yeah,
quickly, people will stop sending you them. And then you can report out that your help desk ticket numbers have gone down, as if that's something that's your goal.
well, in some places it is a goal.
Right. But that, in reality, you should want your help desk tickets going at a good pace all the time, because people are giving you advice that is helpful, but it's work, and you have to respond to it, and you don't have to fix everything, but you have to explain the things you're not going to fix.
Right. Well, yeah, but let's talk about that. Like there has to be a balance, right? So I think we mentioned earlier that, these folks that are using it, I love the fact that this leader was walking around saying, "Hey, what's stupid? Like what do you think is stupid?" Because then they feel heard, and then you're building trust in the relationship, and you need to have that. But what is it that you really can fix or you should fix? And a lot of it is either what's an operational decision, right? This is never an informatics decision. It is never IT's decision. It should be operations decisions about policy and what they're documenting and all of those things. But how do you balance out the thought process of we have to keep the end users in mind. We do need them to have their voice, but and but we can't always take their solution like, hey, if this window was just over here, it would work so much better. We have to find a balance in that. And I don't know. I mean, I think sometimes people get a little bit wrapped up in that because it's operations, or no, well, informatics really should be tied into this and have the conversation. Like, I don't know. I guess it gets gray sometimes.
Well, you're 100% right, and it's all gray. And this is why I tell people, just do what I say and you won't get hurt. Um, and then after they threaten me with firing, I back up from that and try to be more realistic. I think, again, oftentimes the explanation is worth 1,000 redesigns, right? Like, yep, I hear what you're saying. For you, the way you're doing it, it would be better if that window were on the left. Most people don't do it like that. And in fact, if you were up on the, you're you're in the peds ICU. If you were in the neonatal ICU, oh my God, that change would be horrific. And let me explain to you why, because I know you don't go there, but let me explain to you. And this is unfortunately a decision that we have to make for the entire hospital because of the
Right.
way they, for those, and then people are like, oh, all right, so you can't just, it's not an easy fix. I'm like, no, it is not an easy fix. And the juice is not worth the squeeze, right?
Yeah.
And so there are times where we will do a lot of work because what you've pointed out is very important, and we want. But other times it's just, yeah, that's how it works, and you got to get used to it. I think one thing that's really helped in this area that I leverage all the time is the cell phone, or as we call it, the phone.
Mhm.
I Now that I think about it, what other kind of phone is there?
That's it. We don't have
Yeah,
any
I mean,
well, there are landlines,
in the
but
hospital we have landlines, but
yeah.
you know that everyone's gotten rid of their home phones. When I as an elderly person got rid of I don't have a landline anymore. People, it's very common, and I'm as guilty as anyone. I have this app. I love this app. It works great. I got it down. I understand the workflow. I have muscle memory, meaning I'm clicking before the thing is practically there because I know what I'm going to go to next. And then I wake up in the morning and it doesn't work that way anymore, right? Like they've changed the window on my, and now I can't find the button. There is no button because whatever. And I'm like, this is horrible. And I try to figure out how to backtrack to the old version. And then I realize I can't do that. It's impossible. And I hate it. And I want to look for another piece of software to do the same. And it is the end of the world. And then if someone comes to me 2 weeks later and says, "Hey, we heard you were really upset about, our upgrade and the change that we made, and just wanted to know, what's going on." My answer almost always would be, "I don't even know what you're talking about."
Hmm.
Right? Because I complained and I moaned and I figured it out, and maybe it's better actually, maybe it's neutral. Usually, it's not worse. It's worse because it's changed, and I hate change, as does everyone, right? So when I say and let's be honest, it's usually physicians that are complaining. It's not nurses or respiratory therapists. It's the physicians that I can say this. You can't say this, but I can say this.
Well, thank you for saying
Yeah,
that.
yeah. I'll say it. It's always doctors that I'm. Yeah. As an aside, when my kids were young and I worked at Epic, and I would go on a trip and my kids would ask me where I'm going, I would always answer, "Daddy's going to get yelled at by doctors." Um, but
It's
but I
true.
digress. Now, I'm smarter now than I was then. When I get those doctors who are like, "This is horrible," and blah, 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 and I ask them, I give them that phone, metaphor, and I'm like, "Hey,
Hmm.
have you had an app and it was working, and then you woke up and it wasn't working the way you wanted it to, and you hated it, but you figured it out, and then 2 weeks later you had no idea how if I would have asked you how did it used to work 2 weeks ago, you wouldn't even be able to tell me." And every single person I've ever kind of thrown that out, they're like, "Yeah, I see that." And I'm like, "Okay, so why don't you just do this? Why don't you just use the software for a month or something and then
Yeah.
come back and talk to me? I'll still be here and you know how to get a hold of me." And then every now and then they're like, "Yeah, it still sucks." And I'm like, "Okay, now we can have a conversation, right? Now
Right.
I'm ready
Right.
to have that conversation." But most of the time, 80, 90% of the time, they're like, "Yeah, I don't even remember what I was complaining about, but I'm sure I was right." And I'm like, "Yep,
Of course you were right.
perfect,
And that must be
perfect."
a vendor thing because when I worked for a vendor, we did the same thing. We used the phone analogy saying it's just pushed out there. You have no choice. At least in this case, you have a choice, but you didn't come to the meeting. So make sure you come
Yeah.
to the meeting next time when we're making these decisions, right? So let's kind of come in for a landing. I would love to talk about this for a couple more hours. So we'll have to have you back, Craig, to talk some more about all of this. But I just wanted to end with your pearls of wisdom, really, and what you've learned over the years. And, even after writing this book, what do you want to tell the listeners?
Yeah, I'm going to change it to Pearl. Pearl. singular of
Just one
wisdom.
pearl. All
Or
right.
just one
Well,
pearl. In the word, and just one word, intentionality. I dropped that word earlier. Intentional. Be intentional when you are designing workflows, when you're designing a room, when you're designing a technology. I said that I'm not a designer, but then with another idea, we're all designers. We've all, hey, what should this form look like?
true.
What information? We all have designed something. We designed our houses and I'm not talking about interior decorating. I'm talking about where the books go on your bookshelf.
Mhm.
We all kind of are responsible for that at work and at home, and just kind of thinking before we do, just stopping for 10 seconds or 10 minutes to say, like, okay, why are we here? We're here to talk about this form. Okay, why do we have this form? We have this form because we need this information. Okay, is this information not available anywhere else so that we don't have to try and get it again? Can we just get it from a different source and present it? And just that stopping before you just jump into leveraging technology in a certain way is so very helpful. And whether you're an expert or not, whether you've read a design book or not, thinking about what you're doing before you do it, it's almost like the timeout we do in an OR now, which we never used to do 20 years ago. Hey, what are we doing? Where are we? What procedure are we doing? Do we have the right patient? Is the laterality identified? Am I, are we on the right hand or the left hand? That intentionality, that kind of just stop for a minute and make sure we know what we're doing, why we're doing it before we do it. Let's apply that not just to the OR and to other things, but let's apply that to all parts of our life when we're designing, again, a tool, a workflow, a technology. I think that is the major problem. We don't even think, we just do.
Perfect. Thank you for that advice that crosses everything: work, personal, informatics, IT, it crosses everything. So thank you for that. And thanks for writing your book, Designing for Health, the Human-Centered Approach. It makes so much sense. And thank your co-author as well when you see him, because I think it's a really great book.
I don't talk to him anymore. No, I do. And I will tell him. Thank you.
Awesome. Well, thanks, Craig. We'll have to have you back.
My digits.
Absolutely.
Thank you for joining us today. We hope you'll join us again for another session of Informatically Speaking.
This has been a production of the Greater Delaware Valley chapter of the American Nursing Informatics Association. For more information about the GDV-ANIA chapter, visit us at community.ania.org/Greater Delaware Valley/home.